Today we're going to talk about the differences between the medical model and the educational model of physical therapy. So you have a kiddo and they have developmental delay, or they're struggling with their gross motor skills, and you find yourself in a position where services may be being offered in both the educational setting and the medical setting. Or maybe you're a physical therapist in the school-based setting or the educational setting, and you're trying to explain to parents what is the difference between your scope of practice in the educational setting and the outpatient physical therapist scope of practice in the medical setting. We're going to dive deep into the differences, the similarities, and how you can really explain to parents and how both can work together to serve the kiddo. The medical model is going to be the traditional setting in which most people think about when they think of pediatric physical therapy. The medical model deals with developmental gross motor milestones, rolling, walking, crawling, sitting up independently. They look at the quality of that movement. How does that movement compare to normal, typically developing peers? And what can we do as pediatric physical therapists to ensure that a child has the best chance for optimal movement? The take home here is that medical model physical therapy for children is specifically designed to work on the quality of the movement and to improve a child's ability to move. It is also deemed medically necessary by the physical therapist as well as the medical doctor or physician. The way that they determine whether physical therapy is medically necessary is through an evaluation process. So the physical therapist meets the child. There are a lot of states right now that you can go straight to a physical therapist to get an evaluation. It's called direct access and it's awesome. A physical therapist goes and evaluates your child, and they determine whether or not it looks as though your child is below their typically developing peers or that gold standard of movement. And if your child is below that, either in coordination or strength, range of motion, then they may deem that physical therapy services in the outpatient setting are medically necessary. The child may also just need a couple of sessions to kind of get them back up to where their peers are, or to help solve a specific problem, especially if the diagnosis is due to an injury or a specific orthopedic concern. The educational model, school-based physical therapists, their scope of practice is slightly different. While they also work on movement impairments and helping kiddos navigate their environment, as do the medical model of physical therapists, school-based physical therapists have more of a limited scope of practice in which they can provide their services. Due to federal and state regulations, educational physical therapists can only serve a student who shows a demonstrated need based on their educational experience. So everything in an evaluation for physical therapy in a school-based setting is going to come back to, is it impacting their education? Federal regulations state that a child needs to be served in their least restrictive environment. And if we were to provide physical therapy services to a child who does not show an educationally relevant need, we would be taking them away from their ability to have free and appropriate education, which is also the regulation called FAPE. There is a hierarchy in the educational system where education is the #1 priority, and having the children in class and absorbing that academic content is the primary objective of the school day. And so if a physical therapist is helping a child, it needs to be in addition to the education. So specifically, school-based physical therapists are going to look at functional impairments that are limiting a child's ability to access their educational environment. Things like difficulty doing things independently. So we're not looking as much at the quality of the movement, although we do want it to be safe and functional. we're not necessarily looking at it being quite to the same level of a typically developing peer, because again, all of our services are going to be based on that dual priority of education coming first and maintaining the integrity of the educational institution. We're going to look at functional activities. Are they able to go up and down the stairs by themselves? The level of assistance required with tasks. How can we educate the people who are working with the children so that they can carry over these skills and support a child in being as independent as possible? And how can we change the environment through accommodations and modifications to a child's school day so that they have what they need in order to do activities at the greatest level of independence possible? If a child is showing that they're becoming independent in a school environment, but they're also still showing that the quality of their movements could continue to improve. At this point, it's really up to either the IEP team or the 504 plan team, which includes the parents as well as the teacher and administrator and the therapist, determine, is the quality of these movements impairing the child's ability to access their education? If the answer is no, the child would benefit from decreasing the service time that a provider is in contact with the child and taking that time and putting it all towards their academics, because this is a school environment, that's what they're here for. But if the answer is yes, that those impairments are still impacting the child's ability to access their education safely, including accessing the playground, including participating in PE, and they also need the expertise of a physical therapist. So you need both the child's impairment is impacting their education and also that impairment needs to be addressed by a licensed physical therapist, and it cannot be delegated essentially to other individuals. For example, if a PE teacher has the expertise to adapt their PE class in order for a child to functionally be able to access it to the level of their peers, the physical therapist's advice and expertise would not be any different from that teacher's. The child would always defer to the least restrictive individual, which would be just that general teacher's knowledge and their skill and expertise. When you're in the educational setting, there's a lot of variety in the scope of their practice. So while the amount of children that demonstrate a need for a licensed physical therapist are smaller in the educational setting compared to in the medical model setting, there is a variety of ways that a licensed physical therapist can impact a child's ability to access their education. There is the direct model, which is essentially you as a physical therapist working one-on-one with a kiddo. And in the direct model, there is a push-in model, which is essentially the physical therapist pushing in to a class. So working directly with the child during a movement break, working directly with the child during a PE class, where the physical therapist themselves is within the classroom environment. And there is also the pull-out method, which is the physical therapist works directly one-on-one with one child or a group of children and pulls them out of class into a separate space in order to work with them on intervention addressing their functional goals in the school environment. And the indirect model is more of a collaborative model where the physical therapist is taking their expertise, teaching other individuals specific things that they can do to influence the child's education, positioning, ability to access the playground, different strategies to improve the child's educational experience. But the physical therapist themselves is not the actual hands-on implementation of that knowledge and expertise. PT will come in and train staff on how to safely transfer a child, and then the staff themselves are the ones typically transferring the child on a daily basis. It could be a gross motor plan where the physical therapist has taught the teacher a couple of exercises that will help the child better be able to regulate themselves. That is a concern. Typically an OT is on board, and so the PT and the OT have collaborated on these exercises and that they're safe for the child. And then the PT will then teach the gross motor portion of these exercises to the teacher. The teacher will implement the exercises for the kiddo within their daily schedule to keep the child calm and able to attend to their academics. It can also be the physical therapist teaches the teacher how to best position, where to place their hands if a kiddo needs a lot of support and sitting. How could you position this child so that the activities that you're doing with the child educationally can also improve their gross motor goals and their ability to be independent. So for a kiddo who needs supported sitting, for example, a physical therapist could teach a paraeducator to support underneath the arm, which then decreases the amount of strength that the child needs to utilize, makes the task easier, and then the child is able to initiate reaching potentially in a supported stander or a supported adaptive chair, or even just supported sitting on the ground. So the physical therapist is working with the paraeducator or the teacher on how to best support the child physically in order to access their education, explore their environment, and improve those play-based skills. That's how interventions look a little bit different in the school-based environment, where the medical model is typically just one-on-one with a kiddo in an outpatient orthopedic setting or in the home. And a lot of the education is really directed more towards the parent or the caregiver that is with the child, either during the therapy sessions or the PT educating the parent directly after the session. And so they're more in a direct model, working one-on-one with the child, versus where in the school-based setting you have these variety of options, because your, again, number one priority is to make sure that the child is receiving an appropriate and free education. The other thing that might be a little bit different from the medical model and the educational model is the evaluation process for physical therapy. In the educational model, the evaluation process, the physical therapist themselves is not the primary provider. The physical therapist is typically part of the IEP team, which is all of the areas of concern impacting the children's education. The teacher and an administrator and the parents are all part of that team, and the evaluation process looks at all of those different components, including academics, fine motor, gross motor, speech and language, articulation, and any other specific area like hearing and vision that could be a part of that child's ability to access their education. The physical therapy part or piece of that evaluation process is typically just one little section, and it is not to be a standalone service in most states. It is a related service, which means that the child needs to show academic need first, and the other areas of concern, such as fine motor, gross motor, are typically under related service, so those would support the academic goals. While in the medical model, the physical therapy services can be the primary provider, the primary service that a child is receiving, as long as it's deemed medically necessary. If a child comes in and the parent has concerns with their gross motor, the parent goes directly to a physical therapist and says, "Hi, I would like to schedule an evaluation. I have these concerns." Or if the parent goes into the pediatrician, or the pediatrician themselves say, "Hey, I have these concerns. I really think it would be appropriate to get a physical therapy evaluation." The family goes in, brings the child in, the physical therapist does the full evaluation, and then directly after that evaluation, typically the parents know, yes, this is something that physical therapy could influence and help improve, or no, I think maybe this other discipline would be better to serve you, or, at this time, these concerns seem to be normal and typical. In the medical model, that is really kind of a one-on-one primary service. Primary objective is the child's gross motor at that time. Where in the school setting, it is very much a longer process. The evaluation process to the implementation of an IEP oftentimes takes up to 90 days, sometimes shorter, sometimes longer. Typically, parent has concerns or the teachers has concerns. Everyone agrees to an evaluation process. There's typically multiple meetings between staff members prior to an evaluation just to collect data, just to know, is this something we want to go forward with, or do we think some of these lesser interventions would produce the same effect? If they choose to continue on to an evaluation process, then that consent is sent home, the parents agree or disagree, they have that right as well, to testing in specific areas. No tests in any areas not on that consent form will be provided. All of those tests will be completed by the staff members and the licensed professionals appropriate for those specific areas. And then once those tests are all completed, they put all of that information into initial eval. You will hold the initial evaluation meeting with all of the members who complete the tests or someone in that member's place that can relay the data of that specific test. So you will never have someone read a test, or you should never have someone read a test to you and explain the results that does not know anything about that test. It really should be a professional, and that is your right as parents to request that someone with knowledge of the test explains the test to you, either on the phone or directly at the meeting. And after the meeting, it will be determined whether or not the child demonstrates a need in 13 areas of specific educational related disabilities that are kind of predetermined by the federal government and the state laws. Sometimes between states are called a little bit different, like significant developmental delay or SDD, or just developmental delay, things like that. You might see a little bit of difference between states. And then once that is done, the parents will either agree to special education services, or the evaluation team will determine that the data that they have collected has not shown that there is a need for special education services, and the parents can also agree or disagree to continue on to an IEP. And the IEP portion itself is really where you lay out specific goals, how the impairments are related to the educational environment, what you're going to work on, service minutes, accommodations, strengths and weaknesses of the kiddo. And then that's really where the bread and butter of what it would look like for your kiddo in the school-based environment and the services rendered. And it is specifically different meeting than the initial evaluation. Due to logistics, a lot of times you will have the evaluation meeting first, directly followed by the IEP meeting, and if any members of the evaluation team collected data that demonstrated that there was not an educational need and parents are in agreement with that, those members are able to leave, and because they then would not be part of the IEP team or IEP meeting, as the child did not show at that point in time functional deficits that were impacting their education. So there's a lot of information and a lot of differences between the educational model of physical therapy and the medical model of physical therapy. And the biggest takeaway that I want you to come away with is really just that the scope of practice in the educational model of physical therapy is much more limited in what they can influence. Any impairment has to be functional and relevant to their education. If a child is struggling with stairs, but they're safe with curbs and there are no stairs on a playground or in the school setting, at that point in time, physical therapy in the educational environment may not be relevant for that child. Again, you can always reevaluate further down the road if a child then transitions to a school with stairs and stairs are still a concern. But at that point in time, that picture and that moment in the child's life, that impairment itself, standing alone, is not enough to be educationally relevant, because again, the stairs would not be in the educational setting. However, that same child in that same moment in season would benefit likely from the medical model of physical therapy, where that child could then work on stairs and alternating going up, alternating going down, with and without a handrail. If that same child worked on stairs in physical therapy in the outpatient medical model of physical therapy, transitioned to a school that has stairs, but is able to go up and down the stairs using the handrail at the same speed as his peers, but uses 2 feet to go down the stairs, that same child may still show that they are independent in that activity in the school setting, but also still benefit from the medical model of physical therapy to continue to work on descending 1 foot on each step. Because that same child is showing a functional ability to navigate their educational environment safely, all the other students are using the handrail, he's able to keep up with his peers, he's not at a risk of tripping. The only difference is they're using 1 foot on each step to go down and he's using 2 feet. That quality of his movement is not necessarily showing that it's impacting his educational experience, while in the same regard, he would still qualify or benefit from the medical model of physical therapy, because in the medical model of physical therapy, they're looking at his gross motor function in relation to his typically developing peers and looking at getting him to the place where he has the most optimal movement pattern, not just that he's functional and safe and independent in the school environment. Those are the difference between the educational model and the medical model. Please drop your comments below because I would love to help further educate on this process. It's a big mind shift both for physical therapists getting into the educational model and also parents who may not have a background in physical therapy or a background in IEPs or special education. So drop your comments below. I will try to help as much as I can or complete some follow-up videos that address your questions. Subscribe if you haven't. It really helps YouTube show these videos to other parents and therapists who could really utilize this knowledge to help benefit kiddos in the future.